Good afternoon. I'm Ann Greiner. I'm President and CEO of the Primary Care Collaborative, and I want to welcome you to this afternoon's webinar, which is focused on vaccines and the role of federal and state government in getting shots in arms, particularly for this last mile. For those of you who are not familiar with the Primary Care Collaborative, we are a nonprofit, nonpartisan organization that is comprised of over 60 members that are very diverse and span all of healthcare. What they share in common is a strong commitment to primary care as the foundation of a high-performing health system. You're welcome to come to our website and learn more about the Primary Care Collaborative and consider joining if you are not already a member. Today's webinar will be 45 minutes. We're doing a slightly shorter webinars in the summer, but we have an incredible lineup, and I will introduce our two speakers in just a moment. For those of you who join our monthly webinars, you know that you can put questions into the chat, and at the end of our proceedings today, we'll have some time for back and forth. We also make our webinars available free of charge on our website 24 hours after the broadcast. So you'll have a chance to listen to them again, listen to the webinar again, or send it to any of your colleagues. So let me begin by introducing our two speakers. Our first speaker is Dr. Bechara Choucair. He oversees the national vaccine effort at the Biden-Harris administration. And as the White House COVID-19 vaccination coordinator, he focuses on coordinating the timely, safe, and equitable delivery of the vaccine across the U.S. And he works very closely with other federal departments and agencies, as well as state and local authorities. Prior to joining the administration, Dr. Choucair was Senior Vice President and Chief Health Officer at Kaiser Permanente. And he really focused there on the social health of Kaiser Permanente members. Before he was at Kaiser, he was commissioner of the Chicago Department of Public Health for 5 years. And prior to that, he was Senior Vice President of Safety Net and Community Health at Trinity Health. So, Choucair, you've really worked in all of the relevant places that we need to better coordinate and integrate to really be successful with our vaccine campaign. Dr. Howard Haft is currently serving as the Executive Director of the Maryland Primary Care Program. For those of you who have attended PCC conferences or webinars, you know Dr. Haft. He's a real leader in Maryland and nationally. During the COVID-19 pandemic, he has served as the medical planner for the United Command and lead on the Vulnerable Populations Task Force. He recently served as Deputy Secretary for Public Health Services in the Maryland Department of Health and the Interim Executive Director of the Maryland Health Benefits Exchange. He's board certified in both internal medicine and emergency medicine. He's had many academic positions. He was founder and chief medical officer of ConMed Healthcare Management, president of the Maryland Healthcare and Multispecialty Clinic in Southern Maryland, and president of the Maryland Foundation for Quality Healthcare, as well as medical director of Health Partners. So Dr. Haft, like Dr. Choucair, has been in all the right places to inform today's discussion about how do we better integrate and coordinate so that we can reach our nation's vaccine goals. Let me first turn this over to Choucair for opening comments, and then we'll hear from Howard.
All right, thank you so much, Ann, for the wonderful introduction. And Howard, it's always great to be with you on a panel. I am so grateful for the commitment and the work that the Primary Care Collaborative has been doing on the vaccination front for many, many, many months. I've been in this role since January 21st, and Ann was one of the very first people I talked to about the role that the primary care providers and health system could play down the line when it comes to the vaccination effort. Let me first just kind of give a brief overview of where we are when it comes to vaccinations as a country. and then maybe give you a flavor of where we are heading in the next couple of months, July and August, these summer months. And then I'll point a little bit further on the role of primary care providers in this stage. So let me just start by how far we've come as a country when it comes to vaccination. We have administered so far more than 330 million shots. And, you know, I have to pause every time I say out that number out loud, because it's just unbelievable how this country came together, how we all rolled up our sleeve and did the best we can to get 330 million shots plus into people's arms. When you look at adults in this country, we're at about 68% of adults have received at least one dose. You look at seniors, 88% plus with at least one dose. You look at 27 years old and up, more than 70% of these folks have gotten the first dose at least. So we've made tremendous progress, and we have to take a moment to celebrate this. And from me, I want to just thank everybody who's watching this webinar here, because I know you've all played a significant role to help us get here. At the same time, we still have millions of people in this country who need to get vaccinated, and we still have a lot of work to do. And I think while the 4th of July was an important milestone, I think, and as I've been telling everybody, we all woke up on July 5th and we're still working equally as hard as we were working before July 4th, because we still have a lot of people to vaccinate. As we see what's happening with the Delta variant and the rise in the Delta variant across the country, we know it's a virus that's more transmissible. It also appears to be associated with more severe disease. And we're seeing, you know, over half of our infections right now are coming from the Delta variant. So we know we have a lot more work to do. The fact remains that if you're unvaccinated, you continue to be at risk, irrespective of your age, irrespective of your health conditions. You continue to be at risk of getting the virus, continue to be at risk of, unfortunately, getting hospitalized and potentially dying. Vaccinations continue to be an important part to help us put this pandemic behind us. And with the rise of the Delta variant, our vaccination efforts becomes even more critical at this point. So we've done a lot of work over the last many months, including engaging health systems, including setting up community vaccination centers, working with pharmacies, working with federally qualified health centers, having mobile clinics, and working with HUD on public housing, working with migrant workers, working with people experiencing homelessness. So we've done a lot of work to get to this point. And as we think about the July, August summer months, if you want, three things to me come to mind. The first thing is we have to continue to better and further integrate the vaccination efforts within the healthcare system. How do we make sure that more and more primary care providers are vaccinating in their clinics? How do we make sure that hospitals are offering vaccines upon discharge, as well as offering vaccines in the emergency departments, and making sure that primary care providers that are part of hospital systems are also getting the vaccines into their offices? So a lot of our work, we're engaging with health plans, ACOs, and other to make sure that we continue to further integrate the vaccination efforts into our healthcare system. The second piece I think that's going to be critical here is to continue to bring as much of the vaccination into where people live and work as possible. We're working with schools and universities to have pop-up clinics in those settings to make sure that students are getting vaccinated. There are opportunities to work with employers to make sure that we are offering vaccination on workplaces so that we can make it even easier for people to get vaccinated. So a lot of that type of effort that make the access easier to people is going to continue to be an important part of our work. And then the third piece that I think is going to be critical for us is to continue to focus on equity. And I think we've made tremendous progress, but yet we still have disparities when it comes to vaccinations, and we have to be able to close those disparities. I mean, just think about the Hispanic community. It's 17% of the population. It's 16 today. 16% of the first doses are gone to the Latino community. We've made tremendous progress. And when you look at the last 3 to 4 weeks, more than 30% of the doses are going to the Hispanic community. So we're seeing good progress there. We still have more work to do in the Black community, but we have to continue to keep equity at the center of our work. So a lot of work to come. I think a big focus on health system, a big focus on continuing to make access easier, and a big focus to closing disparities gap. So I'll pause here, and I look forward to the Q&A discussion, Anne.
Great, thank you so much. And before we turn to Howard, Bechara, I just have one or two questions. You're right, we've been in conversation since February about leveraging primary care clinicians in terms of vaccine administration. And I think we've always found you to be really receptive and really, from the very beginning, understanding the critical role that primary care plays. You probably saw the recent Commonwealth Fund survey of the unvaccinated, and 53% said that they would prefer to get a vaccine in their personal physician or their primary care physician's office. And the next highest percentage in terms of setting was retail pharmacy or drugstore. So clearly there is this big desire for those who still have questions to go, talk to, their primary care clinician and get those questions answered. And how are we doing in actually getting vaccines to primary care? I know that you've been working a lot with the states and the public health departments. Can you give us a little insight into how that's going in terms of actually getting vaccines to primary care offices?
Absolutely. I think, Anne, you've referenced the Commonwealth survey. The reality is survey after survey, focus group after focus group has been very clear from day one that physicians are the most trusted messenger when it comes to the COVID-19 vaccine. Their practices are the most wanting or desired locations for people to get vaccinated, and we have primary care practices across the country. So there is no doubt in my mind that further engaging the primary care providers is going to be key, has always been a key, but particularly now becomes even more critical, particularly for those who still have questions about the vaccine. And we know there's about 12 to 15% or so of the population that still have questions, legitimate questions. And those are not folks who are completely opposed to the vaccine. They're open to the vaccine. They just have legitimate questions. And we want to make sure that we're giving these folks the opportunity to talk to their doctors, the most trusted messengers when it comes to the vaccine, so that they can make an informed decision. And I have no doubt, Anne, that when people get the facts, when people get the answers to those questions, they will be more inclined to making a decision that's going to be about getting vaccinated. So we've been on this journey to get as many of the primary care provider practices access to the vaccine as possible since, I would say, maybe mid-March is when we started working with with the medical provider association groups and others, with states, to make it even easier for people to sign up. And since early April, we've nearly doubled the number of medical practices that are receiving vaccines, that are making vaccines available in their practices. And we know we still have gaps, and we want to continue that journey. So we've worked with the CDC on putting together toolkits of what would it take for practices to sign up to be able to get access to the vaccine, offer the vaccine on sites. CDC is working with states to also make it as easy as possible for the states to make it convenient for primary care providers to sign up. We still have a long way to go, and today's webinar is one of those perfect examples of how we need to continue to spread the word about the importance of this effort. But in a nutshell, since April, we've nearly doubled the number of medical practices receiving vaccines, and we have to continue to do more work.
Thanks so much. And I think we're going to hear from Howard and hopefully get insight from other states as to how they're doing things. And we'll have more questions and time to ask Bechara questions. So Howard, you're in a wonderful position of having, at the Department of Public Health, having a lot of strong connections to primary care practices because of the transformational work you're doing as part of a CMMI grant. And it is, really optimal that there are these relationships because the states that had those kinds of relationships were able to leverage them when the pandemic hit. And I think that's, just such an important effect on the ground about Maryland and other states that have those kinds of long-standing relationships. But if you could give us an overview of, where Maryland is with vaccine levels, what differences there may be across socioeconomic, racial groups, political affiliation either, and just paint a picture for us of how primary care got involved in vaccine administration and what it's been like from your vantage point.
Yeah, and thank you. Great question. And Bechara, it's always great to be sharing time and in these discussions with you. So Maryland, I think, as you said, is fortunate in many ways that we did have already a fairly well-defined primary care program under the total cost of care model with 562 sites around the state. But I think that is not the whole story. The story, I think, really is the same in Maryland as it was pretty much every place else, that initially, as vaccines rolled out, there was an intent to get as much of the vaccine that was available, and remember, it was in short supply to begin with, into as many arms as quickly as possible. So people initially jumped, I think, in many places, let's first immunize the healthcare workforce. So let's go to hospitals and health departments and do that in that way. It makes good sense to do that with a short supply and a very targeted kind of distribution. And then it was getting larger numbers into arms very quickly of the very willing, of the masses, as you would say. And all across the country, Maryland included, it was about having mass vac sites. They sprung up like mushrooms after rain and very effective. But they certainly didn't speak to equity because they were most effective for people who were highly mobile, people who could get into the very sometimes complicated technology required to get an appointment, and sometimes diverse technologies. But they were very good in what they did. And I think as we saw, there was a wave of those that both stood up, did a great job of large doses of large amounts of vaccines in short order. And then they trailed off because they weren't the right answer for everyone. Pharmacies also weighed in, particularly in skilled nursing facilities. But there became an awareness that there was a large group of people who really, as all the surveys said, really not only preferentially, but only want to get their vaccines from their doctors because they're trusted advisors, because they're convenient, because that's where I usually get my vaccines. So like other places, but maybe a little bit easier because we were already kind of talking to all of our providers and saying, your time will come, it's soon, you're going to get vaccines. And they were chomping at the bit to get the vaccines. That the state said, okay, now we have enough. And we really recognize the need to lean in with equity, and let's open up the door gradually for our primary care providers, and see how it works. And lo and behold, it really worked very well. As soon as they got vaccines, they put them in the arms of individuals with a high degree of equity. So Maryland was initially not the highest in terms of equity, but after primary care and our equity task force and others came into play, we really rose almost to the top in terms of equitable distribution. And so Maryland, not just for those vaccines that were given through the primary care program, what it looks like is about 27 or 28% of those that were given to African Americans, which is about parity with our African American population. But for our Latinx population, because we really saw a deficit, we really leaned in with data and programs and encouraged our providers to make sure they were immunizing their Latino patients. We're now at almost 12% when the population is about 10% for them. So we're kind of over and above the representation of the population. And we knew that there was not so much hesitancy in the Latinx community as it was access. They wanted to get access from their trusted community providers. They were a little hesitant about large government organizations, but very comfortable with particularly providers who spoke their language. And we were able to really, really do a good job there. But I think it's the same story all over. Providers want to be able to vaccinate their patients. We just have to find a way to inform them and to organize them and have them work together with our great health departments to be able to find methods to easily distribute the vaccines to them. Also, if we could find a way to do that in smaller quantities, it would be.
Yeah. So thank you, Howard. And I think what we heard from both of you is about this integration and coordination that is really essential for this particular vaccine. I mean, other vaccines, you know, primary care clinicians would just order directly from a distributor, but this vaccine was different for many reasons. And so we have a different distribution schema than we've had before. And consequently that, you know, made things a bit more complicated, as both of you know. You know, you've both worked at public, you know, in public health and in primary care, and you've worked at the intersection. What do you think we need to do to better coordinate and integrate primary care and public health, you know, to address things like this pandemic, and we hope, you know, future pandemics, which we hope are a very long ways off, but we can't be assured of that, but also, you know, to achieve better health outcomes, particularly to close equity gaps. What do you think we need to do differently? Open it up to everyone to jump in first.
Yeah, this is, I'll jump in first because this is an area that's very near and dear to me, and the integration of public health and primary care. You know, I think we've known since I think Bechara has been on both sides of this equation. We know that public health, you know, has some great strategies and has a great insight into epidemiology and great data, but really lacks boots on the ground implementation in many ways. That's not to say there isn't any, but there's not enough, particularly when we have to scale up quickly to address things like pandemics. And primary care has very much a trusted longitudinal connection with the vast majority of the people in the country. Almost everybody, not everyone, but nearly everyone can identify, here's my source of care. And they have great ability to deliver care, but are really not well organized generally over a state span, and lack in population health data, epidemiologic tools, and those kinds of things. When we put the two together, the synergy is just incredible. But it takes recognition on both sides and leadership on both sides. Leadership and recognition on the public health side, to say I want to use primary care as a resource and a tool, and leadership and organization on the primary care side to say, yeah, I think we can gain something from working under public health influence and direction, and particularly in these kinds of episodes.
Yeah, I can't agree more with Howard on this. And again, I've been on both sides. I've spent time in the public health department in Chicago, and I spent time most of my career in the healthcare system. The reality is probably one of the most important lessons that we're learning through this pandemic response is that we need to have a lot more integration between the public health system and the healthcare system, so we're better prepared for the next public health emergency that we have as a country. The reality is these two systems do collaborate fairly closely on a few things, but not on most things. And sometimes the language is different, the vocabulary is different. And bottom line is, particularly on the public health side, the infrastructure isn't strong enough. We don't have enough resources to be able to dedicate for the public health community to further and further integrate with the healthcare community. And on the healthcare community as well, we need more of the awareness about that importance of engagement and the value add that the public health community can bring. So I think, and I'm hoping that we're going to see more and more of the public health departments across the country dedicate additional resources and hopefully have additional resources that they can dedicate to further integrate with the healthcare system. At the same time, we really need to have that awareness and that commitment from the healthcare system to further engage and integrate with the public health community. If we don't get to that point, we would have missed on a big opportunity from a key lesson learned from this pandemic response.
So commitment and leadership, and you both talked a lot about integration. So what is the infrastructure that we actually need to support integration? And you're talking about making investments in public health. I think from the primary care side, we also need some additional investments in primary care. We've actually seen a decline in investment in primary care over the last decade. Now, there's been even less investment in public health. So these are, two sectors that are both underinvested in. But can you speak more specifically, both of you? I'd be curious about what exactly we need in terms of infrastructure. And I'm also very cognizant that, billions of dollars are now flowing to CDC and will soon be flowing to the states on the public health side. So how would you want to, use those funds, to address the issue that you raised about infrastructure? We won't commit you to anything, just ideas.
Well, I mean, I'm happy to start, and obviously this is on my own personal perspective here, not reflective of the administration commitment on that front. But I ran the health department in Chicago, and from day one, I wanted to make sure that this is an integral part of the function of what the health department is able to do. So we made sure we had people dedicated to figuring out how they can best integrate with the healthcare system. Whether it's around lead toxicity, it's not enough that we sit as a health department and wait for the faxes of who's got lead toxicity in the city, so then we activate the nurses and the caseworkers. We needed to have a much more robust integrated system. So that's exactly what we've worked on. And we've even developed modules and modeling tools that would allow us to identify who's at risk of lead toxicity, that flags the primary care providers in their practices while they're seeing this person, and potentially be able to trigger a message to the local health department to more proactively go and engage with this family. I mean, those are the types of examples I think that we need to see a lot more when it comes to the integration between public health and healthcare. And I know there are a lot of health departments that are doing outstanding work on that front. The reality is it's not consistent. It's not happening in every state and every health department, and we just need to have it happening at that location, at that level. And I do think having dedicated teams that are thinking about integration day in and day out, that's what they're doing 24/7. That's going to be key to be able to make a difference. Howard, I don't know, from your experience, what you've seen, or
Yeah, completely agree with you. And I think it would be a travesty if we didn't take advantage of this, what we've just, and don't get the opportunity to rebuild something that's stronger and resilient in the future. And I think it's three parts to it. One part is funding. And I think, as Ann knows, we're really intent now on finding ways to provide funding for comprehensive advanced primary care, team-based care. Think back to even the beginnings of meaningful use. One of the elements in that was syndromic surveillance, which tied public health together with primary care. That kind of got lost along the way, but the idea was there. It was early on that we ought to link these two together, which is, and public health needs to have the funding to be able to build those that data infrastructure to share bidirectionally information, syndromic information coming from practices and data being fed back to providers in terms of how to adjust their care accordingly. That's just, and the pipes are there now. It's not a matter of with interoperability growing, with the barriers against sharing information declining. particularly for these kinds of things, that's really key. That's so funding and sharing information are the two parts. Third part is just having a robust learning system that shares information between public health and primary care. That's one of the things that we saw. Now, it was an advantage because of the pandemic that we had the rapt attention of everyone when we talked about anything about that had to do with the pandemic, whether it was when the vaccines are coming out, how the vaccines work, what we should do for PPE, all of those things. But that's a good conversation to start. And once you have somebody's attention and they know that this is credible information, you can really leverage that into a bi-directional kind of sharing of information that practices can tell public health, primary care can tell public health, what do we need to do our job better? And public health can say, what do we need to do our job better? And the two of them can have a conversation. So having those platforms for communication and learning between public health and primary care, funding, data sharing, and ongoing robust communication, I think is the message for putting those together in the future. And you could do that any place.
I love your optimism, Howard, that we can do it any place, and let's hope that we do. Can you say a little bit more about the Maryland HIE and how that might have helped your efforts? Because you were talking about bi-directional learning, and I think also, if I understood you correctly, information sharing. Can you speak to how the HIE was supportive or not in terms of the vaccine efforts?
Yeah, I think you're very, very, very supportive, critical to everything that we did for vaccines. Certainly, the HIE, we asked them early on if they could make sure they provided to all of the primary care practices information about which of their patients had been vaccinated, who hadn't been vaccinated, when they got the vaccine, what kind they got, and also their race, their ethnicity, underlying medical condition flags, their age, etc. So practices had at their fingertips kind of a more strategic way of looking at their patients when they do outreach. So that was really effective. But it was also a way of saying, how are we doing overall as a state? How are we doing as practices in terms of equity? How are we doing in terms of our overall ability to vaccinate all our patients? And just recently, we put another push out for all. We giving trophies to all of the practices that have vaccinated 90% or more of their patients to date, and we're reaching down to those that have large numbers of unvaccinated patients with additional resources, home visits, and other kinds of things to make it available. That data that we got through CRISP really set us free in terms of sharing information, and I think that's critically valuable.
Let me just add here, because I think what Howard described is so important. And I actually had the opportunity to visit with two of the practices in Maryland that have actually been able to benefit from this level of data exchanges back and forth. And I remember clearly the conversation I've had with Dr. Angela Marshall and her practice, how that list of her patients who haven't been vaccinated yet, her ability, her and her team in the office to pick up the phone, call these folks, have a conversation with them, invite them to come in if they have additional questions, being able to offer the vaccine on site. So when they have that conversation and that patient is at a point where she or he has made their decision to getting the vaccine, be able to offer it on the spot. I think all of those have the recipe, if you want, for success in an effort that would really make a difference. The ability to targeted outreach to your patients who haven't been vaccinated yet, the ability to engage with them, you're their trusted messenger there, and the ability to invite them to your practice, a place where they're so comfortable with, and offer them and giving them the vaccine. That is truly a model that I'm hoping we'll be able to see a lot more across the country. And Howard, thank you and your team, and to Maryland Health Department and the leadership at the Health Department in Maryland for making that happen. It's just outstanding.
Yeah, almost all the credit goes to our great state HIE, CRISP, who really, were willing to stand up in every way to help the state in combating this pandemic. But I think if not every state, most states have an immunization information system that can be leveraged in one way, shape, or form to provide more robust information to providers. Also, to be able to order vaccine through those information systems also. So a lot of the infrastructure is there, just needs to be leveraged and built on.
Terrific. Well, we do want the states like Maryland that have had such success to be scaled across the country. And so I think, there are ways that funds could help, but I also think we're going to need the leadership and commitment of both the public health and the primary care communities to try to make this happen, as well as federal and state officials. So let me ask one last rapid fire question, and then we're going to go to some questions that have come in from the about 200 people who have joined us today on the webinar. So this is a rapid fire. We're going to ask Bechara first, and then Howard. So the question for Bechara is, if you could wave your magic wand, what primary care related policy change would you call for all states to embrace if they have not yet done so to bolster vaccine rates? So very quick, what do you want the states to do?
Well, there's no one magic solution here. Like you the data exchanges that Howard just described, that just adds so much value. You want the small doses availability, the packaging, like Ohio, for example, has done. Now they can do 30 doses per package that goes to primary care providers. You want PCC to be able to enroll easy in the program and get access to the vaccine. So there's really no one magic solution. There's a series of best practices, which we know what they are, and we want to make sure that these are implemented consistently across every one of our states in this country.
Thank you. And of course, it's complicated, right? There's never a silver bullet. Howard, what about for you? For your magic wand, what would you like federal policy to do to bolster vaccine rates?
Yeah, I think I'd like federal policy pretty much along the same lines to say that states shall, with support from the federal government, assure that primary care providers have access to vaccine that they can directly order, and it would be shipped directly to them either through the state or through the federal government, and that it should be provided in the quantity that is appropriate for the week or weeks ahead, according to the provider's known demand. I think that's a perfect system, because at ground level, our primary care providers can well anticipate how many people they'll be able to vaccinate in a week, and they can order or stop ordering based on that demand, and they can also induce demand to be very specific about how to get vaccine to people.
A more flexible and responsive system, and I think both parties would like to see that happen. We had an unusual circumstance, and we had to respond given those circumstances. Okay, so this question is from Stephanie Gleer from the American Academy of Pediatrics. So it's for Bechara, and you spoke a lot about improving access and equity, and Stephanie applauds that. But she also wondered if you could speak to what efforts the federal government is involved in to help address vaccine hesitancy and vaccine skepticism. And might note that pediatricians have a long history in working on this problem.
Yeah, I mean, the reality is vaccine hesitancy is a real problem. It's an issue that we need to address, and we are addressing. We know that it all starts with the trusted messengers, and that's why the engagement with primary care providers, with family docs, pediatricians, family nurse practitioners, physician assistant, OB/GYN docs, it's really important to have that voice there. It's also important to lift up trusted voices in the communities. That's why you'll see us dedicating literally billions of dollars that are going to community-based organizations, faith-based organizations, to build the trust and build those trusted messengers. One concrete example is the development of the COVID-19 core. And this volunteer core has literally now thousands and thousands of people across the country who are getting answers, getting frequently asked questions, getting facts, so that they can be engaged in one-on-one conversations. And it also means engaging in paid advertising. It's bringing out earned media. It takes a village to get us there. At the end of the day, though, I feel like right now we're at a point where matters the most is those one-on-one conversations. And that's why in every media appearance I have, in every conversation I have, I always challenge those folks who are already vaccinated to take a moment to talk to their friends, talk to their neighbors, talk to their family members who are not yet vaccinated and share their experience with them. And we know there's still a lot of people in this country who are in this wait and see category. I think 12% of adults, that's tens of millions of people. And it takes all of us to be involved in those conversations.
Absolutely. Okay, this is a question from Jan Blanchard, and it also in part relates to pediatricians. I mean, obviously now that teens are able to be vaccinated and anticipating those younger than 12, I think a lot of folks who are in the pediatric space are now really tuning in. But the question is, how do we hold health plans accountable for covering the cost of administration? I think some practices have encountered that health plans may not necessarily be providing that kind of financial support. So, what can they do? What is the administration doing on that front?
If there are specific situations that we need to address, please feel free to contact me right away. I'm not aware that this is a concern, but if it is, we'll definitely be happy to take a look at it right away.
Super. Well, thank you for that. And I think, that message of there should not be, there is a perceived at point financial barrier to getting vaccines. We know that that's not the case. That's a message that we need to keep getting out. People are surprised that there's no copay or there's no cost. They don't expect that from the U.S. healthcare system. So that's a message. And also, practices should be supported in terms of administering the vaccine. So that should not be an issue. Okay. As we think about the future, it is a bit uncertain, given the variant and, still about a quarter of the population that hasn't gotten the first dose that is eligible. What are you thinking about in terms of, new ideas, new plans, new strategies to try to close this gap? What is it going to take? Or is it just continuing to work the strategies that we have now? And I open it up to both of you, and I think then we'll have to close it out.
I'm happy to start, and I'll turn it over to Howard. I think we are at a stage where we need to continue to make access as easy and as convenient as possible for people, because we know there are still about 3% of adults who absolutely want to get vaccinated and they still haven't gotten to it yet. But for those folks, we need to make it as easy as possible for them. For the 12% who still have a lot of questions about the vaccine, we need to be able to answer their questions so that they can make the informed decision. At the end of the day, though, Anne, communities with lower vaccination rates and communities with higher percentage of the Delta variant, creates a recipe for a spike. And that's why we are being realistic, and we're putting together surge teams that will be there ready to support states and local government to respond to these spikes, whether it's through added testing, added therapeutics, deploying personnel if needed, as well as the resources of the technical expertise from the CDC, help with data analysis, field investigation. And at the same time, when we have a spike, while we know that we can't vaccinate ourselves out of a spike, we need to leverage that spike to really raise awareness about the importance of people getting vaccinated. By far, nearly all deaths in this country that are COVID related are amongst the unvaccinated. Nearly all hospitalization are amongst those who are unvaccinated. So we know that vaccines work, and we need to do everything we can to spread that message and get more and more people vaccinated. Howard, if you have any suggestions, I'm willing to take notes, so just feel free.
So, Bechara, no, I think +1 on what you said, but in addition, I think just making sure we keep the infrastructure that we built in the primary care workforce, keep those things that have been valuable in terms of pharmacies, local health departments, and others in terms of access points, both for continuing the work here for the residual, but then also so it's prepared if we need to revaccinate, if we need to do boosters. It's better to be able and be easier to ramp up that already existing workforce and access than it would be to start trying to set up tents and mass vac sites all over again. So I think it's continuing, not putting what we built in terms of this infrastructure in mothballs, but to continue building on that and make it ever ready. So I think that's where I'm coming from. And there's 1,000 different ways that you can, home visits and vulnerable populations, barber shops, you name it. There's no wrong door here. There should be no wrong door here.
Right, there we go. Well, thank you both. It's been a really enjoyable conversation, and thank you for all of your hard work and commitment. And I must say that it does give me some comfort that you are thinking, and looking forward. We hope it does not happen, but it seems that it may in fact come to pass, that we're going to have these hotspots that need to be attended to. So let's hope for everyone has a safe and wonderful summer. And again, thank you for all of your hard work on this really important issue.
Thank you, Ann.